So I'm going to talk a little bit today about anterior column support. Sid kind of set me up really nicely for this discussion. We trained together, so I think some of our embedded training there lets us think very similarly. But I do both. I mean, all three actually. I do anterior, lateral, posterior interbody, or trans T-lifts and so forth. I don't do transsacral. I'll declare that right now. But I'm going to talk strictly about direct anterior lumbar surgery. And I'm going to focus a little bit more on revision and deformity surgery. I think, when it comes to a simple degenerative spondy or ismic spondy, that it's probably a dealer's choice in terms of what they're most comfortable about. But I think, as our techniques evolve, we tend to like to go to the newest technique, and sometimes we lose track of why we did things, and especially now being practiced about 20 years, I've come to be able to look back and I trained with Bradford in UCSF, and we did a lot of anterior lumbar surgery, and then the antibodies came, posterior antibodies came, and then the direct lateral. And I've been slowly using those in my practice, but I want to talk about the direct anterior, and I want to talk about three advantages to that. One is increased fusion rate. So I think everyone realizes that some type of interbody, and probably the anterior interbody is probably the easiest in terms of disc preparation or end plate preparation. So I think the fusion rate obviously is increased. Biomechanical considerations of an anterior interbody over, say, T-lift or direct lateral, and then most importantly, sagittal and coronal correction. So I think there's no doubt, as we talked about, that the interbody fusion, especially the anterior interbody fusion, is far superior versus posterior lateral, and I think probably across the board better than most. If you took all T-lifts or all PLIFs, I think the A-lift is just an easier interbody fusion to accomplish. You have a much wider platform to work with and so forth. So the patients I consider important interbody candidates, and I go sometimes anteriorly, are lumbar sacral junction. There's a high pseudo rates there, especially with long constructs. Treatment of pseudoarthrosis itself. So if someone had a previous PLIF or posterior lateral fusion, and I want to correct that pseudoarthrosis, I'll do an anterior column support or anterior interbody fusion. High risk patients, smokers, steroid use, even osteoporosis, I want to provide some additional anterior support. Biological considerations, I tend to still use BMP for my anterior procedures. I've gone away from most of my laterals and posterior antibodies because of the side effects. And then adjacent levels. I think when someone comes back for an adjacent level fusion, that's a high-risk pseudo doing just a traditional posterior lateral fusion. So often I'll do either a direct lateral or a anterior fusion in those levels. So the next area is biomechanical considerations, and I think this is critical. I think I use anterior column support in highly unstable situations. So those are long constructs to the pelvis. Those are patients with significant sagittal deformity. When we're pulling that patient back, there's a lot of force anteriorly, and so I like to use an anterior column support in those situations. High-grade spondylolisthesis, defects anteriorly, such as tumors. Obesity, I often will go anterior and provide additional support, and osteoporosis, as we discussed. I think lumbar sacral fusions, I think the anterior column support provides both structural and biological superiority. So I think at L5S1, to me, that's an important factor. I think I'm going to skip here. The reason why the lumbar sacral junction is important is that the sacrum is really made of some soft bone, and so you want as large of a footprint as possible. And I've even seen my evolution. We started off with cutting our own femoral rings, and then we started going with 30 millimeter footprint cages, and 32, 36, and 40. So now we're getting larger rings, footprints, to allow us to sit on that apophyseal ring. So I think that's important. I think you want to, and that's one of the advantages over the T-lift or a PLIF, is that we'll have these long constructs, and then we'll put these little cages, and those will tend to subside. That was Paul Glazer's also a colleague who trained a little before us with Bradford looked at this, and he looked at the lumbosacral fusions and constructs in vitro and looked at the type of cages, and it did matter. So I think, seeing these larger footprints are very important, especially in these longer constructs. In terms of lumbosacral fusions, I don't want you to think that the cage alone may be satisfactory. I do still back them up with lumbosacral fixation. That's been shown to, one, pull out your sacral screws and subsidence of the cage, but also distal sacral fractures below your S1 screws. So I think this was an interesting study that looked at long constructs with just S1 screws, long constructs with S1 and iliac screws, and then long constructs with S1, iliac, and cages. And they actually found, from a biomechanical standpoint, the iliac screws were most important biomechanically in terms of stability. So to me, that iliac screws or some type of extra pelvic fixation is definitely critical in these long constructs. There's nothing worse than having a sacral fracture below your S1 screws and having to try to fix that afterwards. It's a lot easier to take out the iliac screws after they're fused. So I'm going to move on to really the most important part about anterior column support. And to me, it's sagittal and coronal corrections. Sig showed a lot of this. And with the invention of the direct lateral approach, a lot of the spinal deformities I see are being treated with these direct lateral cages along the apex of their lumbar curve, and then often L4-5 or L4-5 and L5-S1 are left to a T-lift approach or a transsacral approach. And I think they're missing the boat there, because most of these sagittal patients with sagittal deformities, just like the first case Sig showed, is that 2/3 of your lordosis comes from L4-5 and L5-S1. And so when you're missing the boat in terms of getting your best correction by not going anteriorly at those levels. And I think now with the hyperlordotic cages, you can get very aggressive in terms of restoring that lumbar lordosis. And although I think a good surgeon can get some lordosis with a PLIF and a T-lift, it's certainly unpredictable. So the preoperative planning becomes extremely more challenging, whereas I can look at a pelvic incidence and lumbar lordosis pre-op and dial in the cages I want to use, and I can pretty routinely predict how much lordosis I get. Obviously, a PSO is extremely attractive in terms of maximizing lordosis, but much higher risk, much higher pseudo rate, and so the hyperlordotic cages have certainly allowed me to improve on that. So as I said, preoperative planning is important. Larger footprints are also important in terms of preventing subsidence in these patients with larger deformities. Some practical considerations. I tend to get pre-op CT scans on most of my deformity patients. I think it's impressive to realize how many patients have autofused facet joints, where you're trying to do a correction anteriorly first, and you realize you can't gain that correction because of the facet joints fuse. So I definitely get CT scans to look at the facet joints and also bridging lateral or anterior osteophytes that I need to realize I need to release. Doing a hyperlordotic anterior cage to restore lordosis requires a pretty aggressive release anteriorly to release all the osteophytes, to release the anterior annulus, the lateral annulus. And often I'll also go back posteriorly and release the posterior annulus. One of the reasons why is if you're putting in a 30-degree lumbar cage, say at L5-S1, you're lengthening the anterior column, but you're shortening the posterior column. So you're also closing down that foramen at L5-S1. So you have to be really cognizant of that and consider when you go posteriorly to actually go and explore that foramen and open it up. If you can get a cage that has a higher posterior height, then you've indirectly distracted that foramen. So I think if you're using hyperlordotic cages, unlike the traditional lumbar cages that are 10 degrees, say, or 8 degrees, you need to really be cognizant of what's happening with that foraminal height posteriorly. So I definitely do that. I'm just taking a look at my things. I put this on last night. So And then finally, buttress screws. Obviously, I think it's important to realize when you're using these hyperlordotic cages, you're flipping these patients posteriorly and doing Smith-Peterson osteotomies, these cages really have a high likelihood of extruding. So this is kind of just a generalized case that I wanted to kind of show you. This is a woman that's 76, osteoporotic, had a previous L5-S1 posterior lateral fusion many years ago. 2 years earlier, had a L4-5 fusion with a decompression at L3-4. And she presented to my office with that x-ray, the first x-ray there with obviously some significant mismatch in terms of pelvic incidence, lumbar lordosis, but really her major issue was her stenosis and radiculopathy due to the spondy at L3-4. We treated her with 12 months of Forteo first, and then we did a three-staged procedure where we were able to, given her mismatch, right, her pre-op, I'm not sure if I have it up there. Yes, her pre-op pelvic incidence was 59 degrees, lumbar lordosis 23 degrees, so she had about a 35-degree mismatch. And so we picked a 20-degree and a 14-degree cage, and we were able to place those two cages and restore her lumbar lordosis and her overall sagittal balance. And so to me, you could possibly do that with a direct lateral, but you'd probably have to do some type of ACR where we release the anterior longitudinal ligament and it becomes a much more aggressive surgery in my hands. And so this worked out well. So I think the anterior column support is certainly something that obviously many surgeons need to have a vascular surgeon as an approach surgeon, so you have to have that availability in your hospital, but it's certainly something not to lose sight of. I think the coronal correction also is extremely important. And Sig showed that first patient, which I think is very common in a lot of our practices. These patients come in with a thoracolumbar or lumbar curve. They have slight coronal imbalance. They have radiculopathy on the fractional curve, and that's a up and down foraminal stenosis. And I would almost argue with the case that Sig showed that although the overall curve was stable, when they shift to the right like that, that's a gravity sinking that patient down, and that's an unstable patient. I would tell you that in my experience, a decompression alone in that patient is just not going to work. As a matter of fact, if you take a supine x-ray, they often correct their coronal deformity because it's really gravity that's setting them down. And so in that case, sometimes doing less, like a T-lift, you can't horizontalize that lumbosacral junction and the takeoff from the pelvis. And so then when you have to extend them, now you have a fixed angular deformity off the pelvis, which makes it even harder to extend them proximally. So to me, the A-lift at L4-5 and L5-S1, and this is how we started our training with adult scoliosis. We used to do thoracoabdominal anterior approaches. That was the original kind of approach, and we'd take out every disc from T10 down to the sacrum, and we'd put morselized bone at every level, and then cages or femoral rings just at 4-5 and 5-1. And the reason we did that was that horizontalized the patient's takeoff, and then the other disc levels were mobilized and released so posteriorly we could balance the spine. And so I've kind of gone back to that, where often on these big curves like the one he showed with the significant coronal imbalance, I'll put a large footprint which really horizontalizes the takeoff of the pelvis, but at 3-4, 2-3, depending on the CT scan and how much bridging osteophytes, I'll release those levels, but just pack them with morselized bone, and you'll be impressed posteriorly once you do your Smith-Peterson osteotomy. These patients fall, you don't even have to work, they fall right into a appropriate coronal and sagittal balance. And so, putting this concept of putting cages, and in that case Sig showed, the first one, if you did that through direct laterals and then try to do a T-lift at L5-S1, they would have been stuck with a significant coronal deformity that you would not have been able to fix posteriorly. So to me, the A-lift still has a role for adult scoliosis, and I'll show some cases with regards to that. So let me show, let's move forward. So just a quick case here. I mean, this is a woman that has obviously significant sagittal and coronal imbalance. She was slightly obese. She had multiple sclerosis, but she was ambulatory, but literally had a significant deformity there. So our plan with her was to go anteriorly, and my vascular surgeon can often get up to L2 or L1 through an anterior approach. And so we'll put just structural cages at 4, 5, 5, 1, usually hyperlordotic, because what we do is we measure the L5-S1 disc base, and sometimes these patients, they already have about 10 degrees of lordosis in this situation. So you need to go above and beyond that. So it's not appropriate just to measure the difference between the lumbar lordosis and pelvic incidence, but you got to measure the individual lordosis of each disc base and add that to your total cage correction, or else you're going to undercorrect overall. So we put morselized bone graft at L2, 3, L3, 4, and then cages at 4, 5, and 5, 1. And then the rest was done with just a simple posterior release. And this just goes to show you that you can see that we put the cages at 4, 5, 5, 1, but she still has significant collapse. And this isn't a great X-ray. I think the next case shows this. But sometimes they'll have these at L2, 3, and L3, 4, these big bridging lateral osteophytes that if you can go in anteriorly and release that, it makes that disc space a lot more mobile. And so you can see the kind of correction that you can get posteriorly with just an anterior release and so forth. And just one other quick similar case, again, a significant coronal and sagittal imbalance. You can see this is the case that shows, I think it's at 3, 4, 2, 3, that large bridging osteophyte. So that CT scan, again, allows me to understand what levels I need to release anteriorly, and then just putting cages at 4, 5, and 5, 1. This just shows a stenosis, but in the kind of balance that you can correct posteriorly with just 2 cages down below and morselized bone above. So that's it, but my feeling is that I think there's roles for T-lifts, laterals, and I certainly do all of that, but I think for some of these adult scoliosis deformity patients that with the invention of the hyperlordotic cage, I think it's very appropriate, but don't hesitate to sometimes take out the disc and put morselized bone graft that allows you to posteriorly correct, and especially in the coronal deformities, to get a better correction. Thank you.